I'm delighted to introduce Dr. Becky Riggs, who is a pediatric neurointensivist who did her training in Oakland and also Children's National Medical Center, was the first pediatric neurocritical care fellow at Hopkins, was there on faculty for a while, and now is an associate professor in Portland, Oregon, and has led the pediatric neurocritical care subcommittee for the AFM working group. And so delighted to have Dr. Riggs talk about ICU and symptomatic management of AFM.
All right, so thanks so much for that lovely introduction and for inviting me out. It truly is an honor to speak with you guys today. And I feel like I do need to give a shout out to Johns Hopkins as well as Dornbecker, which is exactly, so I'm at Dornbecker Children's Hospital in Portland, Oregon currently. But I will say that the vast majority of my experience directly caring for children with acute flaccid myelitis was in Baltimore at Johns Hopkins, acutely caring for children in the ICU. And then also chronically caring for a lot of children with acute flaccid myelitis. So often kids coming through the Baltimore area receiving amazing services from the Kennedy Krieger Institute. And unfortunately, a lot of those kids would kind of go between Kennedy and our institution. So that's where I get a lot of my personal experience taking care of these kiddos. So unfortunately, I have no disclosures today. And here's some quick objectives I'm going to run through. As you can see, the top three are all related to respiratory failure. And the punchline is, we try to do everything we can to not have to provide invasive respiratory support. But unfortunately, a lot of these children are going to need it. So we're going to go over some suggested criteria for intubation, extubation, who would benefit potentially from early tracheostomy. And then we'll change gears a little bit and talk about procedural short-term sedation, long-term sedation, and making sure that we're appropriately and optimizing these kids' pain management without over sedating them in these acute phases, which are kind of complicated things. And, this is a very unique patient population that are often cared for in slightly different ways than a lot of the kids in the PICU. So I think it's really important for intensivists to have a good understanding of their pathophysiology, because, we can make a huge difference in these kids' lives if we treat them a little differently than a lot of the other kids in the ICU. All right, so looking at the literature, we know a lot of these kids end up in the ICU. So looking at these studies, somewhere between 50% to 75% of kids suffering from AFM will be admitted to an intensive care unit at some point during their disease process. So again, super important for intensivists to understand their pathophysiology. We also know that a good number of these children, unfortunately, do need mechanical ventilation and an invasive ventilation support. Looking at a handful of studies, somewhere between 30-ish% and 80% in the acute phase of their AFM illness will need intubation and mechanical ventilation. Looking at this study at the bottom, 2.5 years later after the onset, at least in this study, they reported that at that point, only 22% still needed significant respiratory support, but it's still, unfortunately, a decent number of these children. This was an interesting read, a paper that was published based on Facebook responses of parents whose children had suffered or are suffering from acute flaccid myelitis. So 167 children and their parents. And what was reported, via Facebook was that on average, these kids' initial hospitalization were about 49 days, followed then by another 42 days of inpatient rehab. So, somewhere close to a 91-day stay with a lot of these kids, unfortunately, with their acute AFM. And of these reports, about 80% of these kids suffered significant respiratory failure, 25% required tracheostomies. However, the good news is with a tracheostomy that many of them, somewhere between the 6-month to 2-year mark, were weaned off of their ventilators and no longer needed their tracheostomies. Now, not all of them, but a good number of them were able to do that. All right, so now we're going to switch gears and go out of the literature. We're going to talk about some suggestions. And I'm going to say these are suggestions, mainly because we don't have enough information about AFM to really develop true guidelines, true procedures yet. So what the rest of my talk is going to be based on is the suggestions that a lot of pediatric intensivists, neurointensivists, neurologists and rehabilitation folks came together from many different institutions and pooled our knowledge and our experience of dealing with these children. And we came up with these suggestions. These suggestions have also been published in this Lancet article, and primarily most of them are in the supplements. You have to find the supplement, but basically everything that I'm going to go over here is included in that supplement. All right, so the number one thing from an ICU intensivist standpoint is as soon as you're worried about potential AFM, airway protection, you got to make sure your patient is protecting their airway. And if they're not, you need to help them protect that airway. Now, the children at greatest risk for respiratory failure are going to be those who have significant cervical spinal cord injury, high cervical spinal cord injury. So C3 to C5 is going to put them at greatest risk. But not only for respiratory failure. So the other thing too is the heart is directly innervated between the C3, 4, 5 level of the spinal cord. So if you have injury to the cervical spinal cord where the heart is directly innervated, you also are at great risk for hemodynamic instability, cardiac arrhythmias, autonomic instability. So it's not just the respiratory failure, but these kids are also at quite high risk for hemodynamic collapse as well. So the main reasons that a lot of them come to the PICU is for this respiratory and hemodynamic monitoring and support. Most of the support that we're providing in the PICU, though, really is supportive care. We don't have the evidence that we need to say exactly how to treat these kids to reverse the process. Now, with that said, most neurointensivists and pediatric intensivists that I've spoken to who've taken care of a lot of these kids, they give IVIG and they give it early. We do have some data from animal studies saying that there's an antiviral and a nice immune modulatory response theoretically these kids can have. At the same time, some kids are treated with steroids and plasmapheresis. That's a little more on the controversial side. And some of the CDC things that I've seen that, discourage against that. But again, this isn't about treatment. We'll just focus on the supportive care that we provide as intensivists in the ICU to these kids. So while my slides are a little out of order, let's go to here. So respiratory failure, knowing that it's so significant, we should really be doing everything we can to avoid invasive mechanical ventilation if it's safe to do so. So anything that we can do in the ICU to prevent respiratory failure in this patient population can actually make a huge difference. So early mobilization, getting PT, OT, PNMR involved from day one, helping support if at all possible. Being overly aggressive with the pulmonary toilet, frequent suctioning, chest physiotherapy, IPV therapies, cough assists, maybe over treating with nebulized mucolytics and things to help keep the kids' lungs open, keep their airways clear, just really give them the best chance at not needing to be intubated if possible. We're going to minimize all of our sedatives, minimize our sleep aids, minimize anything that's going to cause any further degree of neuromuscular weakness. Feeding these kids is controversial. If we're worried about respiratory failure, we're going to keep them in PO because it's safe that way. If they're developing significant bulbar dysfunction, it's also not going to be safe to feed those kids. But at some point in the future, you're going to need to start feeding them again. And before any of these kids eat by mouth in the recovery phase, they all deserve an extensive swallow study if they've had any degree of bulbar dysfunction during their ICU stay. And all of these kids should be overly supported with non-invasive non-invasive ventilation, whether it's BiPAP, CPAP, high flow, and particularly while they're sleeping at night, just to make sure their lungs are staying open and they're not collapsing down. So with that said, we're going to do everything we can to support these guys non-invasively, but unfortunately we know a lot of them are going to need to be intubated. So we need to be able to identify who those patients are. And in my personal experience, all the children that I've intubated or my partners have intubated, it's been their poor bulbar functioning, the loss of vocalization. They go from being able to speak to being able to whisper to not being able to communicate with you at all. And it's usually those triggers that happen far sooner than some of our other objective markers. But your child who can't hold their head up, they have poor head control, they're drooling, they can't speak, They can't raise their arms, they can't shrug their shoulders. Things along those lines are really screaming out that they are at very high risk for needing to be intubated. So we're going to monitor these kids with side stream and tidal CO2 monitoring. And if they're over 6 years of age, we're going to try to do negative inspiratory forces, or NIFs, or forced vital capacity, is somewhere between every 2 to 4 hours, to make sure that these patients aren't getting weaker and that they're maintaining the level of strength that they have, or maybe they're getting stronger. But the key is to make sure they're not getting weaker. Now, if kids are younger than the age of 6, they often can't perform NIFs or forced vital capacities. But what they can do is they can sing, they can hum, right? So can they get through the first verse of Mary Had a Little Lamb in a single breath? Or how far can they count in a single breath? Come up with something that they can actually do based on their age and their cognition, and then ask them to repeat that same thing over and over every 2 to 4 hours to make sure they're not getting weaker, to make sure that they're maintaining their respiratory effort. All right. And so again, if kids need to be intubated, if they're suffering respiratory failure, they're doing so because of profound weakness and bulbar dysfunction. It's from hypoventilation. So it's all about carbon dioxide retention. It is not a hypoxic respiratory failure. So we actually try to avoid giving these children oxygen if at all possible, mainly because once they start desaturating, once they start becoming hypoxic, it's actually a pretty ominous sign that their carbon dioxide levels are rising, and that's the etiology of their hypoxia. So we avoid giving oxygen to these kids so that we can have a better sense of what their carbon dioxide is. Otherwise, we might mask that their carbon dioxide levels are running if we're just hyperoxygenating them. So the kid who becomes hypoxic without another good reason is one that most likely needs to be intubated, because most likely their carbon dioxide levels are rising significantly. They also often become sweaty, have widened pulse pressures, are tachypnic, are tachycardic. Those are all signs of carbon dioxide retention. So going back to our other objective markers, those vital capacities that we're getting, once they're less than about 20 cc's per kg, that patient probably needs to be intubated. Once the NIF is less than negative 30 centimeters of water, or the carbon dioxide levels rising greater than 50, these are often objective markers that we use for intubation. But again, like I said, my personal threshold has been that inability to swallow, speak, and manage their secretions, which happened before a lot of these other objective things did. Now, if you do need to intubate, we strongly suggest, if it's a young child, to consider a nasal intubation over an oral intubation, primarily because nasally intubated children just don't need as much sedative. And again, avoiding as much sedation as possible in this patient population really will benefit them a lot more. Now, once these kids get intubated, it is very difficult to get them extubated, because again, they got intubated because of neuromuscular weakness, which is not the reason the vast majority of children get intubated in the ICU. Most kids get intubated in ICU from a hypoxic respiratory failure, from infection, from ARDS. So all of the markers we have as intensivists to say you're safe to extubate, if profound neuromuscular weakness is your problem, you're going to fail all of our traditional extubation readiness tests, unfortunately. Which, as you can see, if these children, say, are electively intubated or get intubated and don't necessarily need to be intubated, then they may be caught up in this catch-22 of, well, now, even though we electively intubated you, you're not passing all the markers of extubation safety or extubation readiness. So unfortunately, these kids can have prolonged intubations in the ICU because it's difficult to decide as an intensivist when to safely extubate them. So what our suggestions are is, once a child gets intubated, try to minimize their ventilatory settings, put them in an MMV mode of ventilation, or just provide pressure support and PEEP. Give them enough pressure to keep their lungs open, but allow them to set their own respiratory rate. Allow them to participate as much as possible in their own ventilation so that they can undergo ongoing pulmonary rehab, as opposed to over supporting them with the ventilator to where now they're just riding the ventilator and they're getting weaker and weaker because of that. right? The AFM is already making them weak enough. So we need to do everything that we can in the ICU to not feed the cycle of weakness and to allow them to exercise and rehabilitate themselves to a safe degree. Now, at the same time, if they're huffing and puffing and becoming exhausted, well, that's also not beneficial. But the point is to try to allow them to participate in their own ventilation if you can safely do so. So prolonged extubation readiness test or prolonged periods on pressure support and PEEP, in the same manner, thinking, okay, if I extubate this child, I can provide this same level of pressure with BiPAP, CPAP, high flow, something along those lines. And if it really is pressure all that they need, then that kid can most likely be safely extubated. Now, if you have a child who does not have a cough and does not have a gag and cannot protect their airway, then those children should not be extubated, and those children should just go on, have a tracheostomy placed, get them to rehab sooner, and start getting them stronger. Again, looking at the data, hopefully they will become stronger. Hopefully they will not need their tracheostomy long term, and getting them out of the ICU with less sedatives and less weakness and getting them to rehab sooner would benefit those children greatly. It's my suggestion and many of ours from the committee, if you're going to extubate any of these children, to do it straight to BiPAP, CPAP, high flow, over support them from a non-invasive standpoint. Try to match up a similar degree of non-invasive positive pressure that you had while they were intubated. So talking now about tracheostomy. So the traditional ICU thought is any child who fails extubation twice without a new infection, without a good explanation, we should probably start considering tracheostomy in them. Like I said before, though, if you have a child who doesn't have a cough, doesn't have a gag, and is so profoundly weak, and it doesn't seem like that's going to come back in the next handful of days, then those children just need to go ahead and have a tracheostomy placed to get them to rehab as soon as possible. We know that the longer breathing tubes stay in children for whatever reason, it puts them at risk for ventilator-associated pneumonias. Co-infections in this patient population can really set these children back, can again just feed the weakness, prolong their ICU stay, delay them from getting the inpatient rehab that they really need. Some institutions are offering diaphragmatic pacing as a way to avoid tracheostomy in some of these children as well. All right, so now we'll transition to sedation, pain management a little bit as well. So if your child needs to be intubated, like I said, if they're really that weak, they probably have significant high cervical spinal cord injury, so they probably have a degree of autonomic instability or cardiac arrhythmias that they're also having. So anytime you're going to intubate one of these children, I would strongly suggest having volume ready to push if you need it, having some dilute epinephrine, having atropine, even considering having your pads already placed on the child's chest with a defibrillator there if they go into a shockable dysrhythmia. I've seen wide complex ventricular tachycardias, bradycardias, very unpredictable arrhythmias around induction and intubation with a lot of these kids. So if you have a child that's showing signs of autonomic instability, they're very high risk for spinal shock, hypotension, bradycardia with induction. And we would strongly suggest being heavy-handed on ketamine. Somewhere between 1 to 3 milligrams per kilogram is actually about all that these kids need because, again, they're really weak to begin with. Now, if you give them some ketamine and they start having some tachyarrhythmias or become profoundly hypertensive, then taking the edge off with a little bit of propofol, I mean, just a little, 0.5 to 1 milligram per kilogram. But again, a lot of these kids don't need much sedation around their intubation. If they don't have a cough, they don't have a gag, and they don't have the ability to vagal when you intubate them, then they may not even need to be paralyzed. But if they do, we suggest using rocuronium and going at the lower dose, 0.6 milligrams per kilogram, if you can get away with it. Now, if you have a child who's not showing any signs of autonomic instability, no signs of cardiac arrhythmias, then you can also do kind of a more traditional induction with single agent fentanyl. Somewhere between 3 to 5 milligrams per kilogram is most likely going to be more than what you need. And again, deciding whether they need some rocuronium or not, and if they do, staying at the lower end if possible. So that's intubation. Now let's talk a little bit about procedural sedation. And again, I can't emphasize enough to try to avoid electively intubating these children. If they need some sedation to get them through their MRI, consider some dexmedetomidine, considering putting an LMA in these kids. Try not to intubate them if they don't need to. Now, if they need it to keep them safe, then by all means, you intubate them, you keep them safe. But if they really don't need it and it truly is elective, really try to get creative with your anesthesiologist or your intensivist here. Because again, a lot of these kids are pretty weak and they don't really need a lot to get them through, whether it's their lumbar puncture or whether it's their MRI or whatever other procedure that you might be sedating them for. We're going to try to avoid opioids and benzodiazepines, but if for some reason you have to give them, give the shorter acting ones, right? So give fentanyl over Dilaudid, give midazolam over diazepam. And again, for those long MRIs, try to get your high yield sequences. And if there's any way you can cut the time down when these kids are at the peak of weakness, get the shorter MRI then, and then, a week later, 2 weeks later, when they're stronger, when they're less risk for respiratory failure, potentially getting the longer, more predictive diagnostic images if it seems reasonable to do so. And then also, providing environmental comforts, parents, child life, things like that, to try to keep these kids happy without having to sedate them and feed their weakness and put them at risk for respiratory failure. So, some kids might end up in the ICU intubated for weeks at a time and might need more sedation. But even a lot of those kids, because of their weakness and because they're really not very uncomfortable because of how AFM has affected them, they don't need continuous infusions like most other children in the intensive care unit. And if they do need continuous infusions, a little bit of dexmedetomidine will go a long way with them. So really trying to avoid giving them the traditional sedatives that we give most children in respiratory failure in the PICU. Really considering giving gabapentin, giving clonidine, giving intermittent agents as opposed to continuous sedatives. And so finally, let's talk about pain. So I've talked a lot about sedation because, the ICU, we're all about sedation. But these kids legitimately do suffer a decent amount of pain. Now, again, this is not evidence-based. This is anecdotal, pooled information from a lot of people who've taken care of AFM kids, but roughly somewhere between the first 2 weeks of onset of paralysis, these kids all develop significant muscle pain, so muscle spasm pain. And so a little bit of Valium will go a long way. Now, I know I keep saying, don't give them benzos, but if they truly are in pain, again, a little Valium to make them more comfortable, to allow them to move, to allow them to do their PT and OT is the right thing to do. Somewhere, between 10 to 14 days after the onset of the paralysis, the muscle spasms actually start going away, getting less, but then significant nerve pain can really start to affect these kids. So as you're weaning down and getting off their Valium, starting them on some gabapentin and slowly increasing that gabapentin to where you can get their nerve pain under control, in that week 2 to week 3 after the onset of paralysis is really important. And again, making sure that we're treating these kids' pain so that they can participate the best that they possibly can in their rehab so they can start getting stronger. So we don't want to oversedate them so they're too sleepy to do their PTOT, but we also want to make sure that they're comfortable enough and that it isn't pain and discomfort that's keeping them from doing their PTOT as well. Another thing to consider, if these kids can't close their eyes, which a lot of them do, have difficulty keeping their eyes closed, have they developed corneal abrasions? So having ophthalmology take a look and making sure they don't have corneal abrasions. And if they have developed them, making sure that we're treating those appropriately with some ophthalmic drops. So again, just to kind of wrap it all up now and summarize ICU, acute management of AFM is, again, respiratory failure. It's all about hypoventilation secondary to weakness. and bulbar dysfunction. So make sure your patient's protecting their airway, and if they're not, you need to protect it for them. People should have a very low threshold to send these kiddos to the PICU. If you're worried at all about high cervical spinal cord lesions, for both respiratory failure support as well as cardiac monitoring and support as well. Consider giving IVIG as early as you can in these kids, despite the fact that we don't have a ton of good evidence yet. And when in doubt, over support them with non-invasive high flow bypass CPAP. Minimize your sedatives, try not to electively intubate these kids, and do everything you can to get them to their inpatient rehab as safely as possible and as quickly as possible, and not keep them trapped in the ICU if you can at all avoid it. All right, here's my references, and thanks so much. I appreciate you guys listening.
Great. Thank you so much, Becky. That was a really great overview and just some really practical tips of things that we should consider in our AFM patients, but also with any sort of potential neuromuscular involvement. And so that was really great. As a reminder, if you have any questions, you can put them in the chat or in the Q&A. I think one of my questions is, in your experience, about how long are these patients, if they need respiratory support, whether they're intubated or non-invasive, about how long are they needing that support for?
It's a really great question. Honestly, in my personal experience, it's the kids who are just profoundly weak and have no bulbar control that we perform early tracheostomies. And those kids don't stay long in our ICU. They just stay a couple weeks and they go off to rehab. And in my opinion, just watching them do that is so much better than the kids that are somewhere in between. They have a cough and a gag, but it's weak and it's maybe getting a little stronger and maybe not. And I worry that it's kind of those kids in the middle that we leave intubated longer for several weeks. We extubate them. They do fine for 5 or 6 days. They get re-intubated. Then we extubate them again and they do fine for 5 or 6 days. And now we're 6 weeks into their ICU course and we're putting a tracheostomy in them. And then they're going to rehab, 2 weeks, 3 weeks later. And so those are the kids that I struggle, because there's also kids with AFM who just need to be intubated for a couple days, right? And we successfully extubate them and they're not as severe and they clearly didn't need their tracheostomy, right? So there's those ends of the spectrum. It's the ones, though, that I do worry that we hold out hope, they'll get stronger in just a couple days, that we can get caught in that trap of, let's just give them 2 more weeks. And then we can't get them on the schedule for another. And I worry because I have unfortunately seen a couple of kids stay for a couple months in the PICU that they really didn't have reasons other than trying to figure out what their respiratory needs were.
Well, hopefully with the natural history study, we can sort of figure out, is there like a biomarker or some sort of clinical indicator to help with that decision making? So thanks again. That was a really, really wonderful talk.